dear friends and colleagues, I'm deeply grateful for the opportunity and the honor to serve as your president. Over the past 12 months, the leadership of our society has been involved in a comprehensive analysis of our challenges and our opportunities. The issues that we have discussed include increasing our support for research in gastrointestinal disorders, crafting effective outreach programs to attract practicing surgeons from the United States and abroad to our society, vetting the feasibility of an additional scientific meeting outside of DDW, and exploring the potential for verification of centers of excellence in digestive care. And certainly, at the top of our list, presenting both great challenges and great opportunities, is the future of advanced GI surgery training. In this field, changes are being discussed. They would have consequences on all post-residency fellowships. The American Board of Surgery is considering ways to integrate fellowship training in the continuum of surgical education. The American Board of Medical Specialties is contemplating whether to confer certificates of additional qualification to individuals who successfully complete an accredited non-ACGME fellowship. How these changes would affect GI surgery training is not known. But we do know that there is a great opportunity for our society to contribute to the discussion and help shape the future of advanced GI surgery fellowship training. It is this area, the past, the present, and how we would like to see the future, that I will address today. I will begin by reminding all of us about the common bond which unites us, the appreciation and love for GI surgery. And I will follow with a summary of the past and current changes in the landscape of GI surgical training. Finally, I want to focus on the challenges and opportunities that we, as the Society of Surgery for the Alimentary Tract, face, and I will conclude by offering a blueprint for the future. We all recognize that in our careers, we have been the beneficiaries of advanced GI surgery training from master surgeons and great mentors who have influenced and shaped who we are today. So let me take just a moment to recognize and pay respect to three past members of our society who shaped my development. Dr. John Ransom. John was a past president of the Association and was an attending surgeon at NYU during my residency. John stressed the importance of evidence-based medicine long before this concept was accepted and became commonplace. Dr. David Skinner. David was chairman of surgery at the University of Chicago in the 70s and 80s. David gave me my first academic job and mentored me for the next 20 years. Poignantly did so even the very last time I saw him, less than a week before his sudden and unexpected death. Dr. George Block. George was attending surgeon at the University of Chicago. George refined my technical skills. It taught me how to earn the confidence and the trust of a patient, without which the sacred patient-physician bond on which a surgical procedure rests cannot exist. I feel very fortunate to have been taught and mentored by these master surgeons. These were master surgeons who felt equally comfortable with an esophagectomy or a pouch procedure, an hepatectomy or a pancreatic resection. Not only were they master surgical technical surgeons, they also added new knowledge to their respective fields of interest and expertise. Can we duplicate this experience today? I feel that it is incumbent upon us to provide high-quality training for for the next generation of GI surgeons. Such training responds to the needs of our trainees and to the public's request for specialized care. In this moment of needed changes, I'm here today to demonstrate to you that no one better than the members of the SSAT can lead this transformation. The issues of training in gastrointestinal surgery has been debated by several past presidents of our society. In his 1992 presidential address entitled "Is Fellowship Training in Alimentary Tract Surgery Necessary?", Dr. John Cameron stated that there was a real need for such fellowships. And indeed, he was proven right by the multiple fellowships that subsequently developed in GI surgery. Dr. Cameron also suggested there was a need for a national group to oversee and guide quality control of all training programs and turned to the SSAT to take on that role. But the fear of possible fragmentation of surgery as a discipline as we knew it then probably played a role against that, following Dr. Cameron's advice. The following decade witnessed many independent but convergent changes. Laparoscopic surgery emerged as an innovative technology, and fellowship training programs in laparoscopic surgery proliferated, with 40 fellowships started by 1998. During these early years, the program directors of many of these fellowships met to share experiences and explore options for improving advanced GI surgery training. This led to the informal creation in 1997 of the Minimal Invasive Surgery Fellowship Council. 4 years later, the Fellowship Council incorporated into the Council of Fellowship Directors. Yet, there were concerns that these fellowships were mostly based on a new technique, laparoscopy, rather than a comprehensive and cognitive curriculum. These concerns were expressed by Dr. Carlos Pellegrini in his 2000 presidential address, in which he stated that these new fellowships gave disproportionate importance to technique over the cognitive aspects of discipline. In addition, Dr. Pellegrini expressed concerns about the proliferation of informal, heterogeneous, unsanctioned, not accredited fellowships. To this end, Dr. Pellegrini established a Tri-Society Council, which brought together SSAT, SAGES, and HPBA. The Tri-Society Council developed guidelines and set goals for fellowship training, including added exposure to complex GI and hepatopancreatico-biliary conditions, competence with endoscopy, skills in laparoscopy, and appreciation of the multidisciplinary care required by the GI patient. In 2004, the Tri-Society Council and the MIS Fellowship Council merged into a single organization, the Fellowship Council. The SSAT is one of 5 sponsoring surgical societies of the Fellowship Council, and our members hold key leadership roles within it. Dr. Rebecca Minter is the current president. Dr. Rohan Jejaraja is the current vice president. Dr. Matt Hatter is our SSAT representative and is a member of the board of directors. All 3 are SSAT members. One of the most important functions of the Fellowship Council is to accredit fellowship programs that meet established criteria of education and experience for fellows. Currently, the Fellowship Council oversees some 220 accredited fellowship positions in more than 150 programs. Obviously, a lot of progress has been achieved since John Cameron's presidential address. But as my kids would say, are we there yet? Probably familiar to all of you. I don't think so. The issues related to fellowship training are tied to the question about restructuring surgical residency, inasmuch as most people feel that post-residency fellowships need to be recognized as part of overall surgical training. In recognition of the contrast between the rigidly structured 5-year training in general surgery and the ever-increasing number of graduated general surgery residents embracing specialized training with post-residency fellowships, the American Board of Surgery and the RC for Surgery in 2011 began allowing general surgery residency programs some flexibility in training, with as many as 12 of the 36 months of senior residency spent in a single content area, as long as all requirements are met by the end of residency. It was envisioned that this added flexibility would favor early specialization training, with trainees able to track to their area of subspecialty interest sooner than traditional residency training would allow. Preliminary results from a pilot study implementing this added flexibility indicate overall satisfaction by the residents with this new training option. Understanding the full potential of this new flexibility rule could ultimately result in understanding how better integrate residency and fellowship training in the continuum of surgical education. The quality of the general surgery training has been of deep concern to the American Board of Surgery for some time now. Recent legislation, such as the 80-hour works limit and the increased mandated resident supervision with consequent decreased residents' autonomy, have created changes in our general surgery training programs that some fear have impaired our ability to produce a competent general surgeon by the end of the 5 years of training. This seems to be supported by the worsening performance in recent years by graduated residents on the ABS certifying exam and the increasing percentage of graduating residents embracing additional post-residency training. At recent count, more than 80% of graduating residents seek additional training in one of the many available fellowships. However, the abundance of post-residency fellowship opportunities means that requirements for uniformity are needed, so residents can be assured of getting comparable quality experience no matter what specialty or what program they choose. The present system does not assure this level of uniformity. Our society is one of several surgical societies with a representative to the ABS Board of Directors. Dr. Ronald Tompkins was our first representative, followed by Dr. Keith Kelly, David Fromm, and Ted Pappas. Our current representative is Dr. David Mavi, who also is the current chair of the Board of Directors. His term expires in June, when he will be replaced by Joe Hines. In recognition of several surgical disciplines becoming mature and somewhat different in the landscape of surgical training, the ABS established several advisory councils in 2005. The GI Surgery Advisory Council, GSAC, was charged to report to the board and to the GI surgery community on matters of interest such as training, certification, and maintenance of certification. The initial chair was Keith Lillemo. He was followed by Ted Pappas, Chris Ellison, and Ken Sharp. The current chair is Dr. John Hunter, past president of the SSAT. He will become vice chair of the ABS Board of Directors in June and chair in 2016. In addition, Ned Soper is the current SSAT representative to GSAC. With Dr. David Mavi assuming the chairmanship of the Board of Directors of the ABS last June, a discussion was initiated regarding options to more closely align fellowship training with core residency training. At a board retreat earlier this year, a motion was carried that the ABS consider the possibility of changing the timing and the requirements for the written qualifying and oral certifying exams. Although the specifics still need to be worked out, and the proposal has substantial levels of complexity, it is envisioned that residents will be allowed to sit for the qualifying exam after their 4th year of general surgery training. They would then be eligible to take the certifying exam after completion of additional training, for sure another year, probably 2. The training between the 2 exams will be designed to facilitate transition to practice and could be focused on specialty training. In a 4+2 design, fellowship programs could become a structured continuation of a core general surgery residency program. Fundamental to such a design would be assurance at the level of the American Board of Surgery of a quality competency-based curriculum, definition of appropriate milestones to measure fellows' progression, and a meaningful oversight process with strict evaluation of faculty, facilities, and experience of trainees. Although relevant to many surgical specialties, this decision is very relevant to the SSAT as far as GI surgery training is concerned. As I mentioned at the beginning of my talk, there is another issue of potential importance on the horizon. It appears that for the first time, the American Board of Medical Specialties might be willing to allow the American Board of Surgery to confer certificates of additional qualification to individuals who successfully complete an accredited non-SCGME fellowship after passing 1 or more examinations. The Task Force on Recognition of Added Training of the American Board of Medical Specialties, co-chaired by Joe Beisky, Associate Executive Director of the ABS and a member of our society, has recently approved the concept of awarding these certificates. A proposal with specific requirements was sent to COCERT, the Committee on Certification, Sub-Certification, and Recertification, where it was recently received favorably. COCERT will now put the proposal up for a vote by the ABMS Board of Directors at one of their future meetings. And here lies the opportunity for specialty societies, and specifically for the SSAT. If we combine the recent decision by the ABS to develop a method to more closely align fellowships with core surgical training, with a possible vote and a possible favorable vote by the American Board of Medical Specialties on awarding certificates of additional qualifications to graduates of approved non-SCGME fellowships, we could envision specialty societies such as the SSAT, defining fellowship curricula, conceiving competency-based training, providing program accreditation, and supplying content for a final examination. The ABS would then issue a certificate of added qualification after successful fellowship and examination completion. For GI surgery, this curriculum could be composed of 2 years of advanced alimentary tract rotations, or 1 year of advanced alimentary tract rotations, followed by 1 year of rotations focused on a component of the GI tract, the foregut, hepatopancreaticobiliary, bariatric, or even colorectal. So what opportunities have we had so far to engage in this process, to offer our collective expertise, and to shape the parameters of change rather than waiting passively for changes to be dictated to us? Under the auspices of the Fellowship Council, the SSAT and SAGES have formed a joint task force on upper GI fellowship training, with the purpose to define the boundaries of upper GI fellowships, consider what a curriculum would include, and what a certification process for an accredited upper GI fellowship would look like. The task force is co-chaired by Dr. Matt Hatter, who is our SSAT representative to the Fellowship Council, and Aurora Pryor, the SAGES representative, and it sees Drs. Moriyama, Zeninman, and Soper as SSAT members, and Drs. Swanstrom, Mellinger, and Scott as SAGES members. The task force has already started to define the appropriate curricular components, and although technical skills such as diagnostic and therapeutic flexible endoscopy and advanced laparoscopy will be included in the curriculum for sure, the curricular modules will be more disease-based rather than technique-based, a recognition of the concept of discipline fostered by Dr. Pellegrini 15 years ago. This task force was initiated in anticipation of the potential opportunity for societies to partner with the ABS in the near future around the development of standards for the assessment of competence in surgical subspecialty domains not overseen by the ACGME. Obviously, this is an opportunity for us, the SSAT, to share our knowledge and expertise. But in my opinion, this is not the only opportunity. In fact, although one could think that the task of providing well-defined fellowship curricula could be conveniently allocated to specialty societies for their expertise and focus, this allocation does not serve the need to define the curriculum for broader training in GI surgery. This broader training in advance of alimentary tract surgery fellowship, if you will, speaks to the breadth and depth of experience necessary to provide effective and safe care to patients outside of the tertiary and quaternary medical centers. The product of this training would be a surgeon at ease with both elective and emergent operations, with upper and lower GI conditions, with laparotomy and laparoscopy, and with basic diagnostic and therapeutic endoscopy. And here again, this offers another opportunity for the SSAT to exercise leadership. This is where we are in a unique position, having at our core the interest of all GI organ-based disciplines. Working with sister specialty societies in a cooperative and mature way, we can serve as a leader to meld specialized curricula and create outstanding training programs that would unify GI surgery, not fragmenting it. These programs would attract the best and brightest of our graduating chief residents to produce well-trained surgeons that the public will trust. Through both of these projects and additional initiatives, we can position ourselves to play an important role in the overall redesign of GI surgery training, rather than sit on the sidelines and wait to be handed a final product. Our involvement is important not just for the training of the next generation of GI surgeons, but believe me, is also important for the future relevance and growth of our society. I think it's clear that an emphasis on training will eventually pay major dividends for our society. Without a structured and integrated training program, the best and brightest will gravitate to other sister surgical disciplines, which already have a more formalized training program and possibly a board recognition. For example, disciplines such as complex general surgical oncology, or colorectal surgery, or thoracic surgery, or acute care surgery, each dealing in whole or part with disorders of the gastrointestinal tract. If we abdicate training on the treatment of malignant GI disorders to surgical oncologists, and colorectal disorders to colorectal surgeons, and esophageal disorders to thoracic surgeons, and acute conditions to acute surgeons, not much will be left for us to take care of. and our relevance will be greatly diminished. As such, we, the SSAT, need to assume a leadership position in defining advanced GI surgery training for the development of the next generation of GI surgeons and for the continued relevance and preeminence of our society. To this end, I've decided to establish a presidential task force on advanced GI surgery training. It will be composed of thoughtful SSAT members who have been active in discussions on advanced GI surgery training in the SSAT, the American Board of Surgery, the Fellowship Council, the RC for Surgery, as well as other specialty societies. The task force will have a 3-year term. At the end, it could morph into a committee, be sunsetted, or be approved for a second 3-year term by the SSAT board. It will be the purview of the task force to decide which aims to undertake. Yet, without having the presumption to be comprehensive or the desire to be prescriptive, I would offer a preliminary agenda of topics to discuss. 1. As I've mentioned earlier, the SSAT SAGES Joint Task Force on Upper GI Fellowship Training has been charged to provide a competency-based curriculum in upper GI surgery. Our presidential task force could very well decide to offer support and expertise to our representatives in this very critical process. 2, as I alluded earlier, the need for a broader advanced alimentary tract surgery training program is greater now than ever in the past. The products of these fellowships will be trainees seeking broad knowledge of gastrointestinal disorders to respond to the public away from tertiary and quaternary medical centers. Our presidential task force could very well define the optimal curriculum for this fellowship training. 3, the task force should work within the Fellowship Council to develop a stringent accreditation process and provide expert content for the development of a high-stakes examination at the end of a fellowship. This can be done and should be done irrespective of whether the general surgery training is restructured. 4, funding of training positions through the Foundation for Surgical Fellowships is rapidly dwindling due to the multitude of fellowship training programs requiring support and the diminishing support from industry. We need to look at alternative funding sources, and our presidential task force may want to indicate new and innovative ways to support advanced GI surgical fellowships. Finally, should the SSAT develop enduring educational products? Should the SSAT consider the establishment of an educational institute for surgery and for GI surgery fellows? I see many opportunities which the task force should consider. But to assure a tangible and actionable product at the end of the deliberation, I will ask the chair of the task force to update the SSAT Board of Trustees at each board meeting over the next 12 months and to produce a white paper no later than a year from now. During the 2nd and 3rd year, the task force will help with the implementation of the actionable and approved recommendations. Our society has had an influential role in shaping GI surgery training over the last 3 decades. In order to be true to the educational mission of the society, to ensure the training of the next generation of GI surgeons, and secure quality GI surgery for the American public, we must continue our relevant role in the landscape of advanced GI surgery training. Nobody knows exactly what advanced GI surgery training will look like in a few years, but I know that we are at a critical junction that will define it for many years to come. The task is large and complex, but we certainly have the right people right here, in this room, the SSAT, the leaders of GI surgery, to accomplish it. Let's rise to the challenge and create a modern path for the training of the GI surgeon of tomorrow. Let's follow in the footsteps of the past masters so that future leaders of our society will point with great pride to our landmark accomplishments that benefit our specialty, surgery in broader terms, and the public as a whole. Thank you very much for your attention.